Got it.
All right.
Somebody has got some funny background noise. Who's not muted? Emma? Okay. That's
Okay.
better.
Would you like to do the first one, Amanda?
Yes, I won't drive though.
Of course, you're.
I've got a rural connection.
That's right. You have got a rural connection. All right, here we go. I'll drive then. Here we
and
go.
I can talk.
Yeah.
And you can look at the chat. You're going to give me a random one. This is like slide bingo. not sharing yet.
All right, here we go. Share screen.
Interleaving. Okay, cool. All right, got that. View options, exit full screen. Make that full screen. Fantastic. Okay, what I see is multiple slices of skin, two epidermis. It got two. Can we just look at the top piece? I want to see how deep down we're going, because I want to look at the normal tissue first to determine what types of tissue do we have before I talk about anything abnormal. So if you move down to the deep edge, I want to see what we've got. So it looks like we've got, it looks like eyelid or nose skin, because there's abundant sebaceous glands, and I can see at the deep margin there's skeletal muscle, and it's quite thin. So I'm thinking somewhere in the vicinity of eyelid, because this could be eyelid skin and the sebaceous glands near the glands of mole. Okay, and as we move along that piece towards the center, okay, it's a little bit fragmented, but yes, move all the way along. Is it eyelid? Because it seems to be epithelial covered on both surfaces. I don't know, that looks like it's fallen off, and that bottom piece has been reflected. It's two pieces rather than one piece. It's continuous.
But here we've got conj.
Oh, it is conj. Okay, so it's an eyelid margin then. That makes sense. So we've got skin on one side and conjunctiva on the other side. We've got some muscle in the middle, so that must be orbicularis muscle, and the dermis in between those two layers of eyelid is expanded by these large solid islands of basaloid cells, and that's below the epidermis. I see blue balls of basaloid cells. BBB is what I'm seeing. And at this power, I can see like that one on the left side has an accentuated margin, and there's a retraction artifact. So at this power, I think this is an epithelial malignant neoplasm, and it's BBB, and I'm thinking right here and now, I've never seen the slide before, I think it's a basal cell carcinoma. And then I would go in to medium power just to confirm or disconfirm my initial impression. I want to look at that palisade and the split. Oh, looks like a basal cell carcinoma to me. I can see palisade where the long axis of the nuclei is perpendicular to the interface with the surrounding dermis, and there is a retraction artifact around it. So those are features of basal cell carcinoma, and I would look around next. So I've confirmed it's a basal cell carcinoma. I'd look for prognostic factors, which would be the type. I think this is a nodular, possibly nodular cystic. That's a good prognostic factor. I would look for the margins to see it had been completely excised or not. So I'd have to look at all of the pieces. If at the bottom there, if it was a true margin, then it's incompletely excised. But I'd look at all of the pieces.
Yeah. Amanda, what's this stuff?
The clear spaces. Well, that looks like, if we go a little bit closer, I know clear spaces could be lipid, because lipid washes out. It could be artifactual material. It could be air. Now, I'm looking, our clues come from our nearest neighbours, and I saw some sebaceous glands right next door to it over here. So that could be a good source of lipid. And I'm just looking a little bit closer to that. So this might be some extravasated lipid, and maybe there has been destruction of one of those normal sebaceous glands with release of the lipid, the destruction caused by the adjacent tumor, that is.
So we
causing that.
Yeah, so we think that this was like a chalazion caused by the BCC. Yeah.
Mm.
So I quite liked this one because it's got really
now that's beautiful.
Isn't that
nodular?
Lovely?
Yeah.
And over here we've got some more nodules. Now these are small nodules, but I don't think that this is a micronodular pattern, because micronodular, they have to all be like tiny, and it's very infiltrative. It's a high risk infiltrative one. And yes, this could be at the margin, couldn't it?
Yes, if that was the true margin at the edges there, at the surgical margin. So I'm talking about the surgical margin, not the interface between the tumor and the non-neoplastic tissue. Yes, that piece at the top there, that's like a classic basal cell carcinoma nodular, and you can see it's extending from the basaloid part of the overlying epidermis. So this is BBB, blue balls below the epidermis. So that would be a good exam type slide because it's not too confusing.
Yes. Good. So that was that one. So that was a nice straightforward BCC with a little chalazion and some nice normal sebaceous glands around here. So let's stop sharing. Are there any questions about that one?
Oh, is there vascular invasion? One
from the top. Okay, I will share the screen again.
So I saw lipid extravasation. I didn't see that much granulomatous inflammation, but there was sort of lymphocytes.
Yeah, there was. Yeah. Okay, where's my screen gone? Right, here we go. Second from the top, vascular invasion.
How likely would you expect to see that, Diane, in a BCC that looks like this?
I've never seen it.
Very, very rare.
I've seen occasional perineural invasion, but.
Oh, do you think it could be because there's round shapes with a white ring around it? That could look like a vessel, couldn't it? What do you think, Diane? Yeah, so, is that what you mean, Alex? Yeah.
Alex, 2 vessels between the 3 nodules. So Alex, do you want to turn on your...
Yeah, you're almost pointing to it with your mouse just there, that there's a little collection of RBCs there with some basaloid cells in the wall. I was just wondering whether or not that was...
This thing?
Yes.
Oh, okay. Yep. Yep, good to think of that. We always think of vascular and perineural invasion for any neoplasm.
All right, so this is the basement membrane of the vessel, and these are the endothelial cells.
Yeah.
Yep.
And all this is inflammation.
Basement cells, lymphocytes, that sort of thing. So not vascular invasion. Look at that fabulous palisade. It's very good.
Okay, are the smaller nests micronodular? So I think we've answered that. The answer is
no,
they're not micronodular. They're not small enough. They would all, and a micronodular pattern is a uniform pattern. Where you have a uniform, lots and lots of tiny little things.
Whereas those big nodules kind of excludes that in this case, because some of those little smaller groups could just be the edge of one of the big nodules cut.
Yeah. All right. Let's have a look at the next one here. Okay, so this one is quite different, isn't it? It's very, at low power, we can see the normal skin across the top, and then there's this infiltrative pattern through here. And the thing that's infiltrating is lots and lots of little strands of cells, which are blue in appearance, and then there's collagen in between them. If we look around to try and get clues what it is, there are a couple of nodules down here which start to show some palisading and some retraction artifact. These cells have a high nuclear cytoplasmic ratio. As I move around, mitoses are hard to find. But based on the pattern and focally a bit of BCC-like appearance, I'm pretty sure this is a BCC. I have differential diagnoses for these because sometimes basaloid squamous cell carcinomas can look like this. So then I'm left with the problem of prognostic factors and telling the differential diagnosis apart. The prognostic factors were in a high risk group anyway, and I don't like that it is quite close to this margin here. So looking at this margin here, I'll just get the right power. This is a little bit of sclerosing BCC. This could well be a little bit of sclerosing BCC. And these are all bits of sclerosing BCC. So in general, for sclerosing BCCs, I like to see a margin of 5 millimeters, and I don't have a margin of 5 millimeters here. Sometimes 1 or 2 millimeters will do if it's in a delicate place. Another slightly concerning thing from a technical point of view is I'm not sure this is the true margin amendment. So they'll hopefully give you a slide with ink on it. This is why ink's really important, because we can tell where the true margin is. But if this was the true margin, I would say that it was positive.
Yeah.
There's a big nerve down here, which I don't think is involved. I couldn't see any perineural or vascular invasion on this.
So, Diane, you said that there was collagen in between these infiltrating tendrils of basaloid epithelioid cells, but I thought the dermis was made of collagen anyway. So what's special about it?
Yes, so here we go. So this is the normal dermis collagen. It's widely spaced and it's very, very, very wiggly. What does the term sclerosing mean here? Okay, we'll come to that. But this collagen here is slightly different. So can you see that it's new collagen? It's got this kind of bluey look to it. And it's also very, very much more compact. So that's where sclerosing comes from. So if we have a sclerosing carcinoma, it means it generates its own fibrous tissue or sclerosis. Yeah. So it's generating its own dense fibrous tissue, both new fibrous tissue in the form of this blue myxoid collagen, and also this very dense collagen. You can see it's much denser and pinker and solid here compared to the loose collagen of the skin. So whereas the normal skin feels slightly spongy, this will feel like a very, very hard nodule.
I think that field that you're showing there demonstrates that quite well at low power. You can see on that right edge the normal density you'd expect in dermis compared to the lesion. And that's always a good thing, is you compare your lesion to the normal tissue around it. Is it the same or different, to give you an idea?
Because I'm an experienced pathologist, as you are, Amanda, we've seen lots of these and probably wouldn't do immuno on them. But if we were concerned that either a basal cell carcinoma was irritated and producing lots of keratin, or we wanted to know whether this was a basaloid SCC, how would you do that?
Oh, I don't generally do the immunos for those. You can do VER-EP4, can't you?
Yeah. So I think you just need to go that there is immunohistochemistry that can tell the difference between the two of them.
Yeah.
Yeah. Can you differentiate this from the infiltrative subtype? They are the same. The infiltrative and the morpheoform and the sclerosing subtype is all the same.
Yeah. And the point is you identify them as that subtype, and they are of the poorer prognostic factor subtype, because you can see it's hard to get margins. It's hard for the surgeon to know where the margins are, and they're more likely to recur.
Alex says, do we need specific IHC for the exam? No, you need the principles of IHC. So you can use immunohistochemistry to tell the difference between them. Yeah.
Yeah, that was quite a tricky case, actually.
It was good and tricky, that one, wasn't it? All right, so going back to the schedule, am I still... Right, here we go. We'll move out again and we'll compare these two slides. All right, so we'll do that for
slide 2.
So you've got 7 minutes.
Now, should we do student first, or
we'll do it first this time?
Okay, we'll do tutor first.
Tutor first. Okay, so we'll go here, tutor first.
And so we don't get to discuss it afterwards. We have to discuss it now. So ask your questions now.
Okay. I think it might be your turn to talk, Amanda.
Okay, right. Well, looks like we've got 3 pieces of skin, and looking at the shape of it, just at low power, I think it's an eyelid margin because it goes all the way around, and I can see like the tarsal plate on the bottom piece. I can see the sebaceous glands of mole on the bottom piece, and skin adnexy on the very, the deep, not the deep, but the most inferior part of the bottom piece. So it's an eyelid margin. And maybe we can look at, yes, that bottom slice, and it looks like this eyelid has been trisected, 3 pieces, and we're looking at a longitudinal section. I'll just wait for that to render. I think just looking at it at low power, so the conj surface is superior and the skin surface is inferior, and the eyelid margin is over to the right. And there is, at the eyelid margin and extending onto the conj surface, there is a thickening of the epithelium. It's basaloid in color, and the epithelium itself is thickened. I don't actually see anything that's invading into the tissue at this power, although if I do look over to the left, there are a couple of nodules of more bluish cells, which I would need to investigate at higher power, but I would think it might be inflammatory substance because it's not as dark blue. So let's have a look at, see what's happening to that surface. So overall, so if we start at one surface,
Just start at one surface.
Yeah, and we'll note. See, so that was my low power. There is basaloid epithelial tumor at the eyelid margin, but I want to know what sort of epithelial tumor. It's very basaloid, so I think the cells have a high nuclear to cytoplasmic ratio, and I think it's unlikely to be benign. So let's go have a closer look. So what's happening there with the conj? Doesn't look normal to me. Can we go a little closer? It looks very cellular. So it's dropped off a bit there. It's become dehisced. That's artifactual. But I want to know, why is it thickened and what's it composed of?
Those are very purple cells, aren't they?
They are very. They seem much darker than I would normally expect. I don't see any goblet cells. I wonder if it's been replaced by something. Underneath the epithelium there, that looks like inflammatory cells.
Yeah, I think, yeah.
And
this looks like
those little round circles that so there's, the pattern to here is, this is a foreign body granuloma. So the little round eggs in the center of the basket looks like man-made material. They're very round. It looks like suture material. And around it, we have palisading epithelioid cells with really elongated giant cells. This is a foreign body granuloma. So somebody's been here before. Surgeons have been here before. Yeah. Anyway, that's not my problem. I want to know what the tumor is. So, all
right, let's go and see the tumor.
Yeah. So yes, it's previously been biopsied. Oh my God, this looks terrible. So the epithelium has been replaced by this layer of the epithelial cells are disorganized. I can see mitotic figures high up in the epithelium. They're pleomorphic. They have a high nuclear to cytoplasmic ratio. They're not showing normal maturation. So I think this is at least dysplastic, and I want to know the type of differentiation. Is it squamous dysplasia, or is it some other sort of differentiation is shown in this? So far, this looks like an in situ squamous malignancy, but I can see there's like little foamy components to some of these cells here, like little clear droplets in some of these cells. And as I think maybe the, like what's that doing up there? The clearing of the cytoplasm. And if we look in there, I want to determine the line of differentiation, because I don't see any squamous whorls or pearls yet, but I wonder if this might be sebaceous differentiation with those little dots. And I'd be going around to the eyelid margin where I saw that thickest part, because that's, I want to know where the epicenter is of this tumor. So,
And Alex asked, where's the tassel plate? This is the tassel plate, Alex.
yes, yep. See those sebaceous glands and the really thick, fibrous. We can draw a line across it all the way along. Yep. Oh, so what about at the very tip there where there's that bit of black ink? I can see some clearing. Yeah. Yeah. So I'm suspicious that this might be sebaceous differentiation. I can also see squamous differentiation. I wonder if this might be sebaceous carcinoma. So far, it looks like it's in situ, which they often start and creep along the top. If they can go up and down, or they can go down and up. So I'm thinking along the lines of sebaceous carcinoma. And then I'd look at the other sections to see.
Yeah.
So the sebaceous features are intracellular lipid, and yes, they can start from sebaceous glands, but they can extend up the ducts and onto the surface. So that's why we have to look around all the pieces of tissue to see where it might be starting from. So down here's a sebaceous gland. So over on the left side of the field, I see little normal sebaceous lobules, and then I see some ducts with expanded by lipid. And then over on the right side, this is the sebaceous gland, but now it's partly been destroyed because it's got this basaloid proliferation of cells with this little lipid clearing of the cytoplasm. So yes, I think this is a sebaceous gland involved by sebaceous carcinoma. Look at all those mitotic figures. And then, of course, the sebaceous glands are connected to the surface by those ducts. So we don't actually see the connection in this particular slice, but we know anatomically that's how that happens.
Is this invasive, Amanda?
What's that?
Is this invasive?
Well, it could still be within the epithelium of that gland. I would keep on looking. What would you say, Diane?
I think it's still in situ.
Yeah.
We've been asked, is there Pagetoid spread? And I have to admit, I've been desperately looking for it. But I haven't seen any yet.
You see how it's very basaloid, because you'd imagine in your mind perhaps that a sebaceous carcinoma would be like all yellow and full of sebaceous, but here it's actually, we're looking very hard to find sebaceous differentiation, mainly as basaloid. These can be really, really tricky on frozen section.
Yeah, don't ask us to make a diagnosis of BCC versus sebaceous carcinoma on frozen section, thanks.
Because often we can't.
Yeah. Right, so the place to find Pagetoid spread is around the edge, and I can't see it. This top slice has got a really nice example of it growing down into the underlying sebaceous gland, or growing up and out.
Yes, probably started in the sebaceous gland and then grew up and spread onto the surface. So we've got sebaceous carcinoma in situ.
Yeah, and there's more
all over the surface. Yeah.
All right, so yes, sebaceous carcinoma in situ. Is there a differential diagnosis? Yes, there is a differential diagnosis. The differential diagnosis, I think, would be basaloid squamous cell carcinoma, perhaps. Because it is producing some keratin, though it would be basaloid squamous cell carcinoma in situ. I don't think I'd probably include BCC in the differential because it doesn't have any of the palisading or clean. Why in situ again? Okay, so in situ because it's not broken through the basement membrane. Let's
have a look at lower power. We can just appreciate it's respecting normal anatomical structures.
Yep. So this is growing down, out of the sebaceous gland here, but it's still confined by the basement membrane.
Yeah. Remember that previous infiltrating basal cell carcinoma had these tendrils all going out. Here we're doing it, it's got expansion with the adjacent normal tissue. So, and there's a humongous chalazion down there in the deep eyelid skin. Yeah, and another one at the,
There's more sutures, something like that.
More sutures.
Oh, yeah, it's hard to tell, isn't it? But there's definitely a bunch of granulomatous inflammation if we look closer.
Okay.
Work out.
All right. What basaloid means? B is, basaloid. Okay, so basaloid means the cells look blue. And the cells look blue because they have a large nucleus and a small amount of cytoplasm. The corollary is squamoid, where they have a large amount of pink eosinophilic cytoplasm. So I describe basaloid because at this appearance, it's blue and basaloid.
Yeah,
You've got a better definition than that. It looks like the basal cells of an epithelial layer because they are in the germinal layer, they haven't differentiated much. They're fairly undifferentiated. So they have a big nucleus and a small amount of cytoplasm.
Would we ask for this to be sent fresh so we could do an oil red O, Amanda?
Well, perhaps in the olden days you might have done that, but now we have immunohistochemistry, and I just do immunohistochemistry. I don't bother with oil red O or frozen section because I don't want to waste the tissue and have it all fragment up on frozen section, but you should definitely write on your request form query sebaceous carcinoma if you think it might be, because then I would do some special stains, and I would do either adipophyllin,
Yeah.
or androgen receptor, AR.
Yeah.
Androgen receptor. What do you do, Diane?
Adipophyllin.
Yeah, our other lab has adipophyllin. We have androgen receptor, so you don't need to worry about sending it fresh.
Yeah. Okay. There's no dumb questions, Alex.
No, there's no dumb questions.
So would I do a P16? No, I wouldn't do a P16 because P16 is really useful for squamous lesions around the head and neck that are invasive in determining whether or not they are HPV related. But I don't think I'd use it for this. Would I include, I would do colonoscopy at the end of the question like this. So your thinking is, does this person have Lynch syndrome? Because sebaceous lesions do have an association with Lynch syndrome. And these days, yes, I would do DNA mismatch repair testing with immunohistochemistry on all abnormal, on sebaceous adenomas and carcinomas.
All sebaceous neoplasms.
Yes, for Muir-Torre syndrome, which is a variation of Lynch syndrome. Yeah,
absolutely. So we would do MSI instability testing, which is an immunohistochemistry test, which we would do on this slide. And if that doesn't show features of Lynch syndrome, there's no point in going forward for colonoscopy. So we would do prognostic classification for determination if it's sondromic or not.
All right, so yes, I would definitely include that as a perfect. Right, Amanda, I'm going to, someone asked what Pagetoid spread means. So I think I might pop out here and find a picture of Pagetoid spread, since that we couldn't find a good one. Let's find Pagetoid spread.
So what we see in that slide that we've just looked at is like a thick rind that's expanding the epithelium as in situ, thick rind. Pagetoid is like individual little cells coming from below up, individual or small nests of cells rather than a thick rind. Okay, here we go, like shotgun sort of thing.
Let's see if we can find, here we go, right.
And it came from melanomas in the first place.
Yeah. So this is a picture of melanoma with Pagetoid spread. Let's just make this a bit bigger. This is
actually no, it came from breast, nipples, right? Yeah, of course.
Yeah, so there's three things that have Pagetoid spread: sebaceous carcinoma, Paget's disease of the nipple and vulva, and melanoma. So here is the epidermis with the keratin. And this is the base of the epidermis, and the malignant cells, it's like sprinkling pepper through it, I think, little malignant cells popped through it. So we've got normal keratin and malignant cells, the shotgun way. Yeah, that's Pagetoid spread.
It's not that thick, complete replacement. Is there existing epithelium still here in this slide?
Yes, here it is up here. Yeah.
It's still got existing epithelium, whereas in that previous sebaceous carcinoma in situ, it had been replaced by sebaceous carcinoma in situ.
Okay,
Good.
let's go to,
So that was tutor first. So is there another one? Oh, there is. Yes.
yeah, so I was comparing it to this one here.
Okay, cool. All right, your turn, and I'll ask questions.
All right, okay, full scale here. All right, so what I've got here, I can identify some normal structures. So I've got some sebaceous glands along here. So I know that I'm in the skin, but the whole of the skin surface here is abnormal. It has a really corrugated look to it, craggy and corrugated. At low power, I can see that there's lots of keratin on the surface and also little round things here that I suspect might be horn cysts.
Up the top, there's some
really good ones.
egg-shaped ones.
Yeah, but I noticed that it's all confined to the epidermis. So there's nothing here that is spreading below the dermis, just like the other one. We're looking at a lesion that is confined to the epidermis. So that's how I think that they're similar.
Would you call this basaloid as well? Is this a basaloid?
I would call this basaloid. You know, it's quite purple looking, isn't it?
It is, yeah.
Yeah.
Got quite a lot of similarities.
Yeah, that's why I put them together. Yeah.
Yeah.
So this is quite basaloid. We can confirm that it's got these keratinized horn cysts in it now. And it's quite basaloid. Let's have a look at it. Because I'm trying to determine, is this benign or malignant? My differential diagnosis is at the moment, it could be squamous cell carcinoma in situ. It could be some other in situ malignancy like sebaceous, or it could be a third thing, which I know looks basaloid, the basal cell papilloma, also known as seborrheic keratosis. That's why they call them basal cell papillomas, because that's what they actually look like.
Very papillomatous, this one.
Yeah, so I noticed that the basal layers are quite well organized. They are palisaded, but that's normal for basal cells. Like this is a normal hair follicle shaft here, and it's basaloid and around it. We've got normal maturation with keratin at the top, and we've got normal granular cells. And
but Diane, there's clearing of the cells like the last one.
There is, and that's another reason I put it in, because it's a bit confusing, because not everything that's clear in cells is lipid. Sometimes you get glycogen in cells, which is also clear. This is quite a low power scan, but I can see that these cells have got little spikes between them. So all this is confirming to these being squamous cells with a basaloid look to them, and the horn cyst. So it's making me think more of a basal cell papilloma, aka seborrheic keratosis. But then we have this here, which is quite worrying, because could this be invasion?
It's dipping down a lot, isn't it?
It is dipping down a lot.
Oh, look at those nests in the underlying dermis. Are they invasive? Are there blue balls below?
Yes, this is very worrying, isn't it? Except I think that these don't have palisading or retraction around them, and they're developing horn cysts in the middle of them. So what I know is that seborrheic keratoses can have little fingers that go down in a reticular pattern. And if they're cross-cut, they can lead to this pseudo invasion pattern, okay? But see how they're still lobulated and they aren't spreading out, and each of them's got a little kind of crevice that they're all spreading out from. So it's kind of like these bits cross-cut.
Can you explain horn cysts a bit more? And why is it called horn? What's to do with horns?
So when keratin is very, very compact, it forms a horn. You've seen them on people, these keratin horns. So it just means it's compact keratin. So what's happening in these horn cysts is that in these whorls, the basal cells are maturing in a fairly orderly fashion to form these little nests of squamous cells. So putting it all together, I haven't seen any mitoses or pleomorphism. They are maturing normally. It's not invading, but it does have this reticular pattern in places. It's forming lots of keratin, and it's basal and a papilloma. So I would conclude that this was basal cell papilloma, aka seborrheic keratosis. but I'm putting it together with the other one because in the compare and contrast, it could easily be mistaken for it. And so what we have to look for is the fact it's benign, it doesn't have the pleomorphism or mitoses, the fact that it's forming lots of keratin with characteristic horn cysts, and it is a papillomatous pattern.
Those horn cysts are a really big clue here, because the horn cysts demonstrate that the epithelium is able to do the amount of differentiation required to make squamous stuff. So there's a couple of questions here. Nishan asks, to what degree of palisading would change this into an atypical or malignant neoplasm?
Not so. Palisading isn't a criteria for malignancy. So it could have any degree of palisading, and I would not think it was malignant. In fact, all these benign hair follicles and sebaceous glands here, they have lots of palisading around them. So palisading just indicates that they are basal cells and not the degree of malignancy.
Yeah, so the basal cell carcinoma recapitulates this pattern, but that's not the malignant feature. It's a feature of the line of differentiation rather than a feature of malignancy. And is there a proliferation of basal cells? Well, there must be a proliferation of something. So
let's have a look here. So yes, the basal cell papilloma, aka Seborrheic Keratosis. Yes, so let's have a look. The basal cell proliferation goes to about here. So normally the basal cells would be here. The basal cell proliferation goes to about here when they mature into these spiny keratinocytes and then the granular layer and the keratin.
So if you were to divide up that epithelial layer there into thirds or quarters or something, so what thickness would normally be basal cells in a normal epithelium?
So normally the basal cells would be, you know, in the bottom 10%.
10% only, but here it's about, what do you think?
Yeah.
80, something like that.
Yeah.
Yeah. So yes, there is proliferation of basal cells. That's part of the lesion. Good. Okay. Right.
Stop here. Time to go to breakout groups to have a look at compare and contrast those two lesions. In the compare and contrast, I really would like you to make sure that you can tell the difference between benign and malignant and can appreciate the foaminess of the sebaceous cells.
Perhaps the driver could have both screens up and you could flick between the tabs of both of them and we can compare and contrast. Yeah.
Okay, off we go.
And stop record. Oh, it won't record in the room anyway.
Press record. And then we'll look at the schedule again. Where are we for the schedule? I'll just schedule. Okay.
Okay, hello Diane.
Hello, we're all back now.
We're all back.
That was good. Now we're going to nip into this one here.
Yeah. There was one thing that I think we should clear up, a misconception I think that came through about, I can't remember who said it, but I think we should clear this up, that if you think it's a sebaceous carcinoma, you can do frozen sections which would determine if you're going to do an exenteration. How would you like to be in that situation, Diane?
Oh, no, please do not do that. Because as you know, the basaloid sebaceous carcinomas look very much like other basaloid things. Please do a biopsy and determine what it is, and then do an exenteration if you feel you have to.
So that's when you do your mapping biopsies and you put them in formalin and get them fixed and processed normally. Mapping, formalin fixed. not mapping by frozen section. Okay, good. Had to clear that one up.
No,
Right.
no, it's really dodgy, you know, because even when like you're doing Mohs, I actually spend quite a lot of time sometimes trying to work out whether it's a micronodular BCC at the edge or a normal hair follicle, because they're about the same size and they've all got little palisades around them, and
That's
frozen
so hard.
terrible
Yes.
for cytology. It's really hard. Yeah.
Yeah.
Okay, so we're going to do this one here, number 3, and we're going to put
Okay.
everyone into groups first.
Yeah, student first.
Yep. Yep, off we go and have a look at it. I'm going to give you a slightly shorter time for this because I think you'll get it straight away. Remember to think about the prognostic features. Recording and share screen, and here we go.
New option, exit full screen. Right,
Okay,
good.
here we go.
Mhm.
So, where is the normal tissue? The normal tissue is around the edge here. Yeah.
Is it totally normal? Why is it so blue looking?
That's a really good question. Right. So here we go. This is skin with keratin. Epidermis is of normal thickness, matures fairly normally, looks fairly orderly, but it's blue. So this is sun damage. This is elastotic change here. The sun shines on the collagen and the collagen degrades, and we call it elastotic because it gets this weird broken down elastin in it that stains like elastin. So this is very sun damaged skin. The bit over the skin over this side isn't quite normal. It's kind of thickened, but not very dysplastic. And then we can see like this, where this lesion begins here and here. Okay, so it's a lesion that exists in the dermis, and at low power, I can see that it's infiltrative, but it's got lots of pink areas in it. So it's not entirely basaloid. So it is a tumor infiltrating the dermis. Is this benign or malignant? Well, have a look at this pleomorphism and these atypical mitoses.
That is ugly.
This is clearly very malignant. So it could be a squamous cell carcinoma with quite a lot of basaloid areas, or it could be a BCC showing squamatization. But as I look round, this shows no palisading at all, no retraction artifact, and we're getting little areas of keratin maturation with this quite nice keratin whorl here and here, and lots and lots of pink keratinizing cells. So I'm thinking that this is a squamous cell carcinoma. Prognostic factors, well, the base is clearly involved. It is completely excised. It's moderately differentiated. I could not see any perineural or vascular invasion.
Could you point out prickle cells?
Oh, sure thing. All right. Let's find.
So yeah, why would prickle cells be interesting in this situation?
Yeah, they would help us tell whether it was squamous. So here's some prickles here between a line of cells.
So these are little intercellular desmosome junctions. Yeah, and there's a little bit of edema in between, so they look like little prickles. That's how the cells are holding together.
Yeah.
So good thinking, Luke. It's a type of evidence of squamous differentiation.
It is. Yeah. Yeah. So other prognostic factors are the depth of invasion. Yep. And the size of the tumor. So it goes into the deep dermis, so we can't see where it goes. So I would say that this section show a moderately differentiated squamous cell carcinoma arising from the dysplastic epidermis and extending to at least the deep dermis within sun-damaged skin. Margins of excision are positive at the base, no perineural or vascular invasion.
Good.
Good. So I think this is a nice straightforward SCC. Do we need a break now, or should we press on and do the next slide, which is going to be
size? We do measure size. Of course, bigger is worse. So
Often the size is measured on the macro.
Yeah.
I don't include it in the micro, but yes, the diameter is important. Yeah.
So in the AJCC staging criteria, there is different stages for different sizes, which we can look up if necessary, but I don't have them memorized.
Yeah, so I memorize, I think from a stage 1 to a stage 2 for the face, it's 2 centimeters. Or invasion, yeah, or depth.
Yeah, but
Oh,
you need to know
depth
size
weight
is a
is millimeters.
prognostic.
Yeah.
Yeah.
Yeah, so the size is prognostic and is related to stage. Is it 2? I think it's 2 millimeters.
Yeah, to go to a P1 to a P2.
Yeah. Yeah.
P2 stage. So of course size is prognostic. You know that. Bigger
Yeah.
is worse.
Okay.
Common sense.
Mind if I don't? Yeah. So the depth of invasion is a prognostic factor. And just say it goes
Okay.
deep. You'll be right.
Yeah.
Right. Okay. So
how are we going? 12:42.
let's quickly run through this lovely slide here as teacher led. Okay.
Okay.
We'll have a short break. All right. So we are eyelid margin, skin.
Yep.
Conge.
Yep.
Tassel plate should be here. This is
Oh dear.
tassel, and there's a bunch of stuff happening, isn't there? So the stuff happening as a kind of nodules here, I can see, with little lipid droplets happening. Let's start here where it's more normal. So I can a lot of.
What happened to that? How do you know that's tarsal plate? Oh, it's all nodular to me.
Yeah, I think I just know the anatomy of the eyelid. And
that one's a bit better there.
Here
yeah.
and the skeletal muscle here.
Mm.
Yep, so I know this must be tarsal plate. Yeah, so here we've got normal sebaceous glands that through here, but they're becoming very inflamed and kind of clogged up. And there's a whole lot of lipid in them and lots of lymphocytes infiltrating them. We've got a really gorgeous set of giant cells through here. Where's that? That's around the base of a sebaceous gland. What's in this sebaceous gland?
What's that brown thing, that long stuff?
I think that this is an eyelash.
Oh yeah, it could be, yes.
You have dark, thick brown hair.
It's like a foreign body reaction, yeah.
It does look a bit like foreign body. Imagine there's other...
It's quite deep down.
There's other pigment here as well. Did you know that sometimes people who work doing coffee grinding, they get pigments in all of their sebaceous glands get clogged up by coffee pigment. That was at the side there. And then
coffee here too.
Got lots of other giant cells. Right, giant cell, giant cell, giant cell, and lots of lipids. So we've got a granulomatous inflammation, a nodular granulomatous inflammation around lipid. Yeah, here we go.
So, well, we saw one sebaceous carcinoma and that had that before.
It did. So why isn't this a sebaceous carcinoma? Question. So I think the giant cells indicate that this is a granulomatous reaction. Plus, we've also got some other inflammatory cells here. So most of these are inflammatory cells, giant cells, and in this case, neutrophils around this little bit of lipid. So it's not a neoplastic proliferation because it's got giant cells and inflammatory cells in it. All these are foamy macrophages. Now, this can be a bit of a trick, I guess, because they are quite foamy, right? Because they're taking up lipid as well and making that foam. But if we see the giant cells, then I think that we're pretty good for a granulomatous inflammation.
And what are those two white holes?
Here, they're the lipid that has been taken up by the machine and dissolved out.
So the lipids, those big lipid holes, then they're not actually inside cells.
No, I don't think they're spilled out. That's why we're getting a giant cell reaction to them.
Okay, whereas the other lipid is inside macrophages, so that's really small lipid droplets. So it's confusing. Lipids all different sizes.
Yes, I've never seen out of a slide set such a good granulomatous reaction. And they've taken the eyelid out, so they must have been unable to cure this by other means. It's very unusual.
It is unusual, or suspected to be sebaceous carcinoma hiding underneath it, perhaps.
Maybe they thought it was. Okay.
Because it's gone all the way to the skin side, which is
Intrigued what this brown thing is.
It is in one of those. It is in a pilar unit, isn't it? That's going down towards the eyelash, and the epidermis is quite pigmented. It's probably a pigmented person.
Yeah. So this is. I think this is just again. I was thinking, oh, it's an organism, but I think it's just a really darkly pigmented eyelash.
Here, I think, isn't it?
Here, yeah. Okay, could I point it out? So Nish says, could I point out the epithelioid histiocytes within this? All right, okay. Right, so let's come back over here to some of these nice granulomas here. So looking at this granuloma, we've got, sorry, the giant cells, the neutrophils, and all these pale cells here at the epithelioid.
Hang on, Diane, you've got some sort of lag. Okay, now it's come up. Okay.
All right. So giant cell, lipid, neutrophils, and all these are epithelioid histiocytes.
Okay, now we've up. There was a little lag, or maybe it's just me. So what's the shape of an epithelioid histiocyte nucleus?
It's they're classically described as a bit like a kidney, but you've got to get them cut on the right angle. So this one here, you might say it was shaped a bit like a kidney, but if the kidney's cut across the middle, you might just get a nucleus with a little dent in the side that's mostly round.
Or sandshoe footprints on a wet beach.
Yeah, that's a good one. Sandshoe footprints on a wet beach. Yeah, like that's a good description of them. That could be someone slightly misshapen sandshoe, couldn't it?
Yeah. All right, but we can look at that perhaps in our individual groups. Fabulous granulomas.
I wonder if we should just go to breakout and not do the groups, because we need to catch up time a bit.
Oh, okay, yep.
Okay,
break
so
time.
5 minutes break. I'm going to.
Oh, yeah.
Yeah, great. I'll just stop recording to make a new section.